What's up guys, welcome to the Nurse Nook. If you're new here, welcome. My name is Alexis Nicole and I make videos all about nursing, lifestyle, and wellness. I recently graduated with my master's to become a neonatal nurse practitioner. And if you're wondering what the heck is a neonatal nurse practitioner, this video is for you. I'm gonna be explaining all the ins and outs of what being a neonatal nurse practitioner means and how it's different from being a neonatal intensive care unit nurse. I have been a nurse for over 7 years now, and I have been specifically in the NICU for 3.5 years. I recently graduated. I passed my boards a couple of weeks ago, and in a month I'll be starting on the unit as a neonatal nurse practitioner, or NNP for short. Before I get into the meat and potatoes of this video, here is a quick word from our sponsor, Mom Cozy. Thank you to Mom Cozy for sponsoring this video. As a NICU nurse and now a neonatal nurse practitioner, I completely understand the importance of keeping equipment clean. Even a small amount of bacteria can be harmful for newborns with immune systems that are still developing. That's why I always recommend using a bottle sterilizer like this one from Mom Cozy. It automatically washes and naturally steams and eliminates 99.9% of bacteria and ensures every bottle, pacifier, and pump part is safe for your baby. Mom Cozy also offers this portable breast milk cooler, which I think is the coolest thing, y'all. It offers unique features like extended outdoor cooling without ice and offers a larger carrying capacity, able to fit up to 2 10-ounce bottles. Their zero contamination system has 2 separate inner storage bottles to keep your stored milk safe. Create a safe and hygienic feeding environment for your little one's health by keeping your baby's supplies squeaky clean. Click the link in the description to find out more. So jumping back in, what the heck is a neonatal nurse practitioner? So I'm gonna refer to neonatal nurse practitioner as NNP for the rest of the video because that is a tongue twister and that's tons of syllables. So an NNP is an advanced practice registered nurse that is specifically licensed to work with babies, neonates, preemies, specifically under 2 years of age. So our scope of practice is from newborn to 2 years old. It's important to say that we don't work with the fetuses. So while baby is still in mom, we are hands off. Once baby is born, whether it's vaginally or via C-section, it now is our job. So starting from there, one of my favorite parts about being an NNP that you may not know is NNPs get to attend high-risk deliveries. So high-risk deliveries can look like babies with fetally diagnosed anomalies, babies that are being born with non-reassuring fetal heart tones, babies that are premature, babies that are born using vacuum assist, forceps assist. Really, anytime there is a risk factor during the delivery, the delivering provider will call the NICU team to attend the delivery. At deliveries, NNPs are typically what we call head of the bed, which essentially means they run the whole warmer situation. I would say that they run the room, but the mom is still there and the OB is doing all of their stuff with the mom, and we are just in charge of the baby's care. So for example, baby's born, baby hits the bed. As the head of the bed, you're calling out what you want to happen next. Whether that's asking your respiratory therapist to suction the baby, whether that's asking the nurse to apply leads. Meanwhile, you're assessing the baby during this time. We're performing head to toe assessments. We are intubating if we have to. We are ordering respiratory support. If it's an emergent situation, we are running codes. We are putting in emergent lines all in the delivery room. So for me, the DR, the delivery room, is one of my favorite parts of being an NP. It's a very exciting role and it's also very high emotion. A mom just gave birth and a lot of times it can be very, very beautiful. It can also be extremely stressful, don't get me wrong, because a lot of times things don't go as planned. But it's also really beautiful. Like you have the mom in there crying, the dad's crying. There's a lot of love in the room. I really, really just enjoy going to deliveries. It's one of my favorite parts. And I should have prefaced this by saying, depending on what facility you are, you will have different roles. So some facilities use nurse practitioners as more of a provider to perform procedures, and some facilities use them more in the capacity of managing patients. So where I will be at, we will be doing all of the above. We will be managing the patients as well as procedures, and also getting to attend deliveries. So although very exciting, attending deliveries is a small part of what NNPs do. I would say as an NNP, attending deliveries may be about 20% of what your job entails. In contrast to a NICU nurse, as the NNP, You are making the plan of care for your patients. You are writing orders. You are updating families with new diagnoses and test results. You're prescribing medications. You are performing emergent procedures, running codes, and everything in between. So for me personally, going from bedside to NNP is very intimidating because the amount of responsibility you now have, like, ticks way up. For me, something that was a bit challenging during school was switching my mindset from bedside nurse to now provider. Another big difference is, as a bedside nurse, especially in the ICU, you may have 2 patients to focus on. As a provider, you'd get, let's say, an average of like 8 patients. And so thinking as a nurse, I'm like, okay, I need to know head to toe everything about these babies. I need to know what size OG I have, where it's taped at, what my feeding schedule is, when meds are due. As a provider, these details are not important to you. It does not matter what size OG tube you have. You're not going to be starting the feeds. You're not going to be the one administering the medication. So just having to switch my mind to, okay, like, these small little details are not important. I need to see like the big picture because I have 8 of these babies. I need to know the ins and outs of their pathophysiology. I need to know what their diagnosis is. I need to know what medications there are, what consulting services are on board. What is the plan of care? What is our TPN looking like tonight? What are labs? What labs do we need in the next coming days? So that for me was a little hurdle to kind of just switch my mind back and forth. Because mind you, while you're in school and doing clinicals, you're still working as a nurse most of the time. At least I was. And so when I was doing my clinicals as a provider, I would go back to work the next day as a nurse. I'm constantly like switching my brain back and forth, and that for me like became a little challenging. So let's go through what a typical day would look like as an NNP. I will say, as a student neonatal nurse practitioner, I had a lot of autonomy compared to what I experienced in my RN program. So as a nurse in nursing school, I felt like I was just kind of there as an extra body to observe. I really didn't spend the whole day and do everything and do all my assessments and do all the vital signs and give all the meds. I kind of was like a sidekick to the nurse. However, in NNP school, I feel that you have a lot more responsibility. You are expected to get there early, go through all your patients, have your plan of care, update parents, round on your patients, assess all your babies. So it really, really feels like you're just on orientation. It barely feels like you're in school. It's like, okay, I'm actually trained to do this. I'm not just here as a body to observe. So I got a really good experience on what it's like to be NNP and what to expect when I start in a couple of weeks. So I'll take you through a typical day. I arrive to the unit at about 6:30, get sign out from the night team. I'll get quick updates on anything that happened overnight, anything pending, any watchers, any babies that might not be doing too well or babies that are improving. We just hit the highlights. From there, you get to your desk and you go through all of your patients. We're just gonna say 8 patients for this scenario. So you start with patient number 1, you start at the top, you go through your vital signs for the past 24 hours, any events, so any bradycardic episodes, any desaturation episodes. What has the blood pressure been trending? What are your eyes and nose looking like? How many times has this baby stooled? Is there any emesis documented? From there, you'll start making your plan of care. Always make sure to check your labs. From there, you can kind of see what you want to do for the day. Are we wanting to go up on feeds? Does this baby need to pull back on fluid some? Do we need an x-ray to check our ET tube placement? Are the gases really good and we can wean our respiratory support? You kind of make a skeleton of a plan for each baby. In the mornings, I typically have about 2 hours to go through all of my patients, which sounds like a lot, but when you're combing through all of these babies, it can take some time. Especially as a student, I'm like, fiercely like trying to make sure I'm not missing anything. And so after you get all your, what we call numbers, you get all your numbers, you have your plan of care, now you round with the physician. This part, you guys, was the most intimidating for me. Because as a little baby student, I'm talking to an attending who has been doing this for years and years and years, trying to tell them what I think we should do. Everyone was always so sweet, but it just is so intimidating being like, hi, I think we should take our GIR down in our TPN. So you essentially present to your attending what you think you guys should do for the day. Like I mentioned earlier, some things that we will change throughout the day: weaning down on respiratory support, going up on respiratory support, increasing the calories in our feeds, increasing the volume of our feeds. giving some more nutrition in our TPN, maybe getting an x-ray to check line placement or ET tube placement. How are our lungs looking? Do we look a little wet? Do we need some Lasix to pull off extra fluid? Those are some things that we may or may not change during rounds. Depending on your patient load, you're around for maybe 1 hour up to maybe 4 hours. It really just depends. Every day is different. Some babies that are really critical need more time. After rounds, usually we now put in our orders. So all the changes we made during rounds, we'll put in the orders for the nurses so they can get whatever it is they need, whether it's more feeds from the enteral center, whether it's medications that need to be brought from pharmacy. We'll sit down and put in all our orders for the day. Once those are all in, we'll start updating our notes for the day. And as you're updating your notes for the day, you're calling families or going to the bedside if families are there and giving them an update on any changes you made on their baby and overall how your baby's doing. Usually by the time you're done doing all that, it's much later in the day. Oh my gosh, I definitely forgot to mention that you assess your babies before rounds, but absolutely assess your babies before rounds because you want to be able to present to your attending your assessment, how the baby looks, how's your belly, how your lung sounds. You want to be able to add that in your plan of care. It's essentially backing up your plan. You have to prove why you want to do something. For example, if you want to increase feeds, on exam, baby looked very comfortable. We have good bowel sounds. Our belly's nice and soft. We're stooling well. I want to go up to 160 per kilo on our feeds. And that's typically the way that you would do things. You don't want to be taking a guess. You want to make sure that your assessment proves your plan. Okay, where was I? After you're done calling, updating your parents, usually you'll go through again, walk through their unit, check on your babies, ask your nurses, do they need anything, how the babies are doing with any changes, and then typically night shift comes. So that sounds very simple and easy, but that is like a perfect day. Very, very often things are happening during the day. So you may get pulled away pretty frequently to check on a baby. Maybe a baby is having more bradycardic episodes. Maybe you need to come to the bedside and assess this baby because baby has taken a turn for the worst. You may get called to deliveries throughout the day. It can become really, really hectic, but honestly, the day flies by. Now, what I just explained is a 12-hour shift for NNPs that work 12-hour shifts. All of my clinical experience as a NNP student were 12-hour shifts. Now, it's very, very, very common for NNPs in the community to work 24-hour shifts. Their schedule looks a little bit different. Majority of what I said applies to them as well, but they may just have a different rhythm in how they work because these providers stay there overnight. Whereas we're trying to fit everything into a 12-hour shift, they have 24 hours to be there. The reason for the difference in the shift is in NICUs that are very, very high acuity, you are not gonna get the time to rest and sleep during the night, which is why usually in high acuity NICUs, the NNPs do 12-hour shifts. In the community, you usually have a lower census and a lower acuity, so practitioners do have the ability to get some rest overnight. I'm not saying like they're sleeping a full night every single night, but they have more likelihood to get rest and have a lower patient load as well as lower acuity to be able to withstand the 24-hour shifts. I think 24-hour shifts are great. I could definitely see myself doing that at some point, but I definitely want to get my experience in a high acuity, fast-paced NICU. That was just a quick overview of what a neonatal nurse practitioner does. If y'all have any questions, please leave them down below. Thank you guys so much for watching this video, and I'll see you in the next one.